Good evening, everyone. Hope you can hear me. Can you hear me? Dimuthu,
Yes, we can hear you, Armi.
thank you, Dr. Asita. So, good evening, everyone. At Spice Root Young Doctors Movement, Sri Lankan team, we conduct this GP Cafe, and we believe in creating vibrant platform for continuous learning and professional exchange among general practitioners. Our mission is to bring timely, relevant, and practical updates to the front line of primary care, empowering doctors to serve their communities with confidence and excellence. Clinical update for general practitioners highlights the importance of vigilance in a malaria-free country. Despite elimination status, the risk of reintroduction remains, and awareness among practitioners is vital. And we are honored to welcome Dr. Pubudu Chulasiri, consultant community physician, as our speaker, who will share insights on malaria in malaria-free country. And this discussion will be moderated by Dr. Kiloshini Handavitarna, the regional malaria officer of Anuradhapura. So I would like to invite Dr. Kiloshini to introduce our speaker. Over to you, Dr. Kiloshini. Dr. Kiloshini, are you with us? I think Dr. Kiloshin is having technical issues with joining us today. Anyhow, Dr. Pubudu Chulasiri, welcome you to the today's program. So if you have any presentation, you can share now. I have made you the co-host.
Okay, Dr. Paparami, thank you very much. Good afternoon, all. Since there is no moderator actually, then I will start my presentation from here. So let me upload it in first.
It's visible, but not in the slideshow mode.
Yes, Dr. Chulasiri, we can screen. You can.
What does that mean? You can't see my presentation?
No,
We
no,
can
we
see,
can
but
see.
it's
Yeah, it
not in
should be
the.
slideshow mode. You have to. Yes, better to click that icon in the lower right corner. Yes.
Now,
Still,
yes.
yeah, yes.
Okay.
Can see now, sir. Can
Yeah,
go
you can see it now, no? Okay.
Yes, sir. Yes.
Good afternoon, all. I am Dr. Pubudu Chulasiri, consultant community physician from Anti-Malaria Campaign. And I am the focal point mainly for the control of malaria in Sri Lanka. And I would like to thank the Spice Road Sri Lanka GP Café, the organizers and others for giving me this opportunity because, yes, malaria is in a malaria-free country. I purposefully put that title is, yes, we all think that we are in a malaria-free country. Yes, we are in a malaria-free country. But are we giving full attention or adequate attention for malaria, even though we are in malaria-free country? Because there are lots of misses and sometimes negligence happen from our side. That's why we have to think about malaria even we are in a malaria-free country. So, can't. Slides are not moving. Okay. Why should GPs care on malaria? So I will give you a scenario. A patient with fever who walks into a clinic and complain of fever for 2 days, presence of headache, body aches, and vomiting. So he comes to your clinic, and especially in the present context, almost all these features looks like dengue. But out of all the practitioners, how many doctors will ask about the travel history to any malaria endemic country? Because in this context, the patient has been to Tanzania in an African country and stayed there for a certain period of time, and he returned 3 weeks ago. So he tells you that he has gone to Tanzania and returned, but all these features looks like dengue. What will you do? What is your next step? I will come into that slide later. We have had this kind of situation even in the past. You know that we didn't have malaria deaths after 2007, but in 2023, there was a patient from Tanzania. He had been there for a certain period of time, and he came to Sri Lanka on actually 10th of April 2023. On the same day, he was having fever, body aches, and weakness. So he went to a GP because he had fever, nausea, vomiting, and he was treated. But even though he had given the travel list to Tanzania, it was not considered as an important point. The next day, 12th, 2 days after that, since he was not having improvement for this treatment, he went to another GP because he had vomiting, abdominal pain, and next day 13, since the condition was worsening, one of the family friend, a doctor also seen, and he asked to do a ultrasound scan even. But until then, no malaria investigations done because he was not suspected having malaria. But since his condition get worsened and worsened and worsened, on 14th, he contacted VP in the private sector, and he was not in a good state to even in the general wards, and he was admitted to the ICU, and he was transferred to the major hospital in Colombo, private hospital, around 7 p.m. Only after that, around 11 p.m., he was suspected having malaria, but the report came on the 15th of April, early morning, around 7:30. We were informed that there is a malaria patient being treated at the ICU in this private hospital. The count is very high. Please come and give us the advice and start the treatment. We started to prepare all these things, and within 15 minutes, we wanted to go there, and after 15 minutes, we were informed that patient died. Patient came to the hospital on foot, but within 1 day, patient died. Where it went wrong? The travel history there. He had fever, the features of malaria since day of arrival, and he was contacted by several GPs and treated by several GPs, and he had that situation. And he died after 2007, the first death after 2007. Because of that, he was not suspected having malaria. The DGHS issued a circular specifically saying that if someone is having a travel history to malaria endemic country and coming with fever to you, please suspect malaria and refer for the malaria investigation tests. The next year, 2024, same district, Kalutara district, merchant seaman went to Guinea and stayed there for a certain period of time. Even from there, he had on and off backache, lethargy. But after coming to Sri Lanka, he was not feeling well. But only after 7 days, he just contacted the GP. So we had given the good awareness on malaria because of death, even death last year. And the GP referred that patient, suspected malaria. That's very good. And he referred that patient for a investigation. Unfortunately, he was the investigation was done in a private laboratory and it came as negative. The report came as negative. Then what happens? Next day, the patient was treated with symptomatic treatments, and next day, again he was not feeling well. He came to the GP, and he said that you have to get admitted. And he came to the Panadar hospital. At the OPD, they were told the travel history, but the report was negative and the malaria was excluded. He went to the from the PCU to the ward. Yes, report was there. So malaria was excluded. All the other possible differential diagnoses were thought about. The next day, the patient had fits and suspected in some kind of pathology in the brain because of suspected dengue. Dengue was repeated several times. And the other testing was repeated, but unfortunately, since there was a report of malaria negative, no investigation for the malaria was done. And he was admitted to the ICU. Then only the patient, the VP at the ICU suspected malaria, and we got to know that patient is positive for malaria and having a very high count of malaria parasite. We started treatment. We gave several doses of IV drugs, but unfortunately, patient had gone to the multi-organ failure and died. 2024. What was there? What was the wrong there? Because of having single malaria testing, the malaria was excluded. No repeated investigation, at least for 3 days, were done to exclude malaria. That is the death in 2024. 2025, actually, the message that we have to get is that he was from Jaffna. He had gone to Ghana, but he after came to Sri Lanka after 5 days, yes, he was having difficulty of breathing, loss of consciousness, chills and sweating. Unfortunately, patient did not have fever. That was the issue. Patient did not have fever. So patient got admitted because of other features, especially difficulty in breathing, loss of consciousness, chills, sweating and others. And after the admission, patient, within 1 day, patient was diagnosed, but patient didn't have a very high count even. Okay. But since patient was having features of severe malaria, the IV drugs were given, but patient died. So here, there is no issue with the primary health care, the context. But the issue was sometimes the patient will come without fever. The fever, yes, it is one of the major features of malaria. Sometimes you get malaria patient even without fever. Then that happened in 2025. And this year, very unfortunate death, a patient who had been to travel to Tanzania, same country in 2023, and a gem merchant. Okay. Hello. Yeah. And patient stayed there for a certain period of time. And after coming, only after 9 days, because just after coming to Sri Lanka also, patient was well for 9 days, but after having fever, on and off fever from 1st of June 2026, for 6 days, he has not gone to any doctor, any GP. He treated by himself with paracetamol.
Okay.
And on the last day, just before,
Very good.
on the last day, 7th of June, since he was severely jaundiced and he was feeling really unwell, he got admitted in the evening to the Kalubowil hospital. After that, SR suspected malaria at around 12 p.m. but asked to get the testing done in the next morning. SR didn't know that even at that time, around 12 p.m. in the night, the anti-malaria campaign is ready to do malaria testing if we were informed. But we were not informed. So in the next morning, patient was transferred to the ward. But since there were the huge crowd of dengue patients, the testing was delayed and not done. And around 12:30, we were given a call from one of the friends saying that there is a malaria patient. Sorry, he was treated as leptospirosis because he had jaundice and other features of fever and other features of leptospirosis. Around 12:30, one of the friends of the patients informed us saying, there is a patient, a friend of mine, who is being treated as leptospirosis, but malaria is not suspected. Please check it. And we just arranged to do all the testing. And after 2 hours, even though we wanted to go and get the treatment, the patient got arrested and patient died in the evening. So the issue was, yes, ideally, if you suspect malaria, there are enough facilities in country that we can do testing within 2 hours of time. At anywhere in the country, we can do it within 2 years of time. It may be night, it may be early morning, it may be a public health holiday. There is no issue. If you suspect malaria, inform us, inform the headquarters, and we will do the testing within 2 hours of time. And we will start, if the patient is positive, we will start the treatment within 2 hours of time. So unfortunately, in 2020, this year also, we had one death. Okay, so these were the tests. But there are some cases also we have to discuss to just focus on some mistakes that we do. Here, this patient in 2026, patient had, actually it's a person from Algeria. It's a patient from Algeria. Here what we have to get is, when they come here, especially foreigners, they tend to travel in everywhere in the country because they are coming as tourists. So if someone is missing, if they get features of malaria, and if we miss them to diagnose as malaria patient, he may have spread his malaria parasite to the everywhere in the country, because malaria vector is available in most part of the country. Here, he had been to Sigiriya, Kandy, and all the other places. And he was diagnosed from Kandy. So we have to, if we detect this patient early, then we can restrict traveling, and also we can do our field investigation very thoroughly early and prevent spreading to the other areas. So this is the case, because here also, look, he had around more than 500,000 parasite count. That means if if we did miss it somehow, the patient would have definitely died. Okay, but we identified, especially the doctors in the Kandy area, especially from the Kandy Asri Hospital, private hospital. One of the professors who had treated malaria patients earlier, he suspected and requested malaria testing from us. We did it. We did it at around 2 a.m. We were informed around 2 a.m. We went there and did the malaria testing. Within 2 hours, we could treat the patient and save the patient. This case, yes, this is the case happened in your district, especially the Anuradhapura district. You can see that the patient from Senapura, okay? So he was there in Solomon Island. He came to Sri Lanka, and usually what we request is, after coming to Sri Lanka, we ask them to get screened for malaria. He had come, he had done 2 malaria screening and it was negative. That means that the continuous, frequent and routine malaria parasite screening is very, very important. But he got features of malaria same day. He was MP done, malaria parasite done, but unfortunately, even though malaria parasite done on 25th, it took 5 days us to diagnose because of the issues with our technical staff. I'm not going to tell it detail, but the issue is sometimes if you suspect malaria, sometimes if you don't refer the patient into a proper place, especially to a hospital where the laboratory staff are there, sometimes you may send it to the private clinics and private hospitals, but sometimes it will take around days to get your report. Okay, because we know that we have to inform you that the PHLT laboratory staff for the malaria is available in almost all the base hospitals in Sri Lanka. So, but there was some delay. But the issue was here, the main issue was there was some, even though patient routinely getting negative, at any point, the patient will be positive. The last case I'm going to discuss now, here the patient was treated in Gampa. Okay, but the patient had gone to 1 day to Mihintale area, Anuradhapura, because he had gone to Mihintale to for the temple and Anuradhapura. Only 1 day. He had stayed only 1 day. But the issue was the malaria vector, the main responsible malaria vector was present when the patient was there. That means if the patient was there with the parasite inside their blood, and if the vector, main vector are there, you have to do all the malaria vector control activities. So even it had gone to the media, අනුරාධපුරයෙන් මැලේරියා රෝගය කමුවේ නෑ, වැරදි මේ කතාව. අනුරාධපුරයෙන් මැලේරියා රෝගය කම්බුන්නේ. The issue was patient from Gampa had gone and stayed 1 day in Anuradhapura within last 14 days. Because of that, we had to do all the activities, distribution of mosquito nets, with this, do the IRS, indoor spraying, okay, and all these activities because of they have a vector in this area. So here the take-home message is, sometimes the patient is not from your districts, but if the patient had come to your area and stayed for a certain period of time, sometimes they may have got treatment from you, but if the vectors are there, definitely there is a chance of spreading malaria in your area as well. We have to do almost all the vector control based on these findings. So these are the cases that I wanted to just focus on, my main parts of lecture, because there are some areas where we had missed. The testing itself, testing 3 times, and missing cases whenever the patient comes to you, sometimes even without fever. Here, this slide shows diagnosis delay. You can see that there is a huge diagnosis delay sometimes among us. Sometimes it will be more than 40 days. And 60, only around 23% of these patients were diagnosed more than 7 days after patient contacted the primary healthcare physician. First contact to diagnose. They come to you, but after that, it takes more than 7 days to diagnose malaria patient, the mass malaria. That is the issue. And mainly these delays are happened in Western province, but we don't worry much about because the vectors are not there. But if it happens in Kilinochi, Putlam, Jaffna, okay, then there will be a huge issue. So I am coming to the malaria. You all know that malaria is a parasitic disease, and there are 4 malaria parasites. Out of them, 2 parasites, mainly the Plasmodium falciparum and the Plasmodium vivax, are more prevalent. The issue is the vector who is responsible for spreading of malaria, Anopheles vector, especially the Anopheles species, are abundant in almost all parts in Sri Lanka, except mostly in Western province. We had a very bad history of malaria in the past 100 years. There were sometimes in 30s, there was a huge outbreak and reported around 100,000 deaths. But in 1963, we almost had a 0 malaria case, near elimination. But with the issues with the government, they didn't consider malaria as a important disease. Lots of cases were missed and the funding were cut off. Because of that, 1967-68, there was a huge malaria outbreak started, and within 2 years, from almost 0 cases to 500,000 cases reported. That's been within 2 years, almost around 500,000 cases reported. And if it happens now, we have eliminated malaria. If it happen now, it won't be 500,000 cases. It will be more than 2 million cases because we don't have any immunity. Those people had immunity, but more than 500,000 cases are reported. But if it happens now, it will be more than 2 million cases. But there were lots of funding, especially the technical input from the WHO and other agencies. We could achieve last indigenous malaria cases in 2012, 23 cases. After that, we are no longer having indigenous local transmission. There is no local transmission in Sri Lanka. So 2016, Sri Lanka WHO issued a certificate Sri Lanka as a malaria-free country. Does that mean we are free of malaria? No, because even though we have eliminated malaria, almost all the countries around Sri Lanka, you can see Sri Lanka is green where malaria is eliminated, but almost all the countries, especially in Southeast Asian region, African region, and South American region, the countries are malaria endemic. Lots of malaria patients are being reported. Local spread there. So if our people visit there, especially India, African region, they can get malaria parasite inside their body and they can come and present as malaria patient. So because of that, in each year, we publish a malaria endemic country list for all the doctors and other healthcare staff. So if anyone has been to this malaria endemic country and present you as a fever case or any features of malaria, then you have to suspect them as a malaria patient. So we are getting imported malaria cases because they are traveling to these countries and present as malaria patients in Sri Lanka. So this year, 27 cases have been reported, including one death. Last year, 42 cases. 2024, 38, and 2022, 62 cases. And most of the cases, more than 50% of cases have been reported from the Western province because the high population and most people go to this malaria endemic country from this area. So the challenge after elimination is, yes, we are getting imported cases. We have the vector and there is a delay of diagnosis. That means elimination is not similar to the zero risk because there are lots of risk groups who are traveling to these malaria endemic countries, especially the tri-forces, army people, Air Force people. They in each year they visit to African region for peacekeeping mission, and they stay there for 1 year and come and sometimes present as malaria patient. Sometimes it will be after 1 month. Sometimes it will be after 6 months. Sometimes it will be even after 1 year. Sometimes they come and present to you as a malaria patient. The second group, gem traders, because 2 days also have reported from this group. So that's why we consider these gem traders as a huge a risk group because they are frequently traveled into African country for gem business and mostly they don't take prophylaxis. So we have to just, whenever they come to you to get treatment, please ask the travel history because they may have traveled to malaria endemic country and got malaria. The migrant worker, lots of people are going to African countries for several reasons, especially for the occupation and pilgrims. Our grandmothers, grandfathers, they visit India for the pilgrimage and come to Sri Lanka and present as malaria patients and tourists. Not only Sri Lankans, even foreigners, sometimes especially people from African region, they come to Sri Lanka and especially Indians, they come for several reasons, especially for work and especially for illegal fishing. They come to Sri Lanka and present as malaria patient and they bring malaria parasite to Sri Lanka. So the case management. The main issue is what will you do if you get a malaria patient? So that is the main part. When should I suspect malaria? That is the most important part should come into your mind. If someone has a travel history to malaria endemic country and if they come with fever, any febrile individual, including foreign nationals, and history of recent 1 year travel to a malaria endemic country, yes, you have to definitely suspect this patient as a malaria patient. And also, if they are belonging to a risk group, especially elderly who has been to pilgrimage, sometimes pregnant women, and sometimes the triforces, yes, they are in the risk groups. And sometimes the patient come with severe features to you directly. Sometimes they come with unconsciousness. Sometimes they come with fits. And if they have a travel history to malaria endemic country, yes, you have to suspect that he may be having severe malaria and on the verge of death. Other features, unexplained anemia, unexplained splenomegaly, hepatomegaly, fever within 3 months after blood transfusion, and non-specific features with the travel history. Yes, if these are there, you have to suspect that patient may be having malaria. And especially if they come with impaired consciousness, multiple convulsion, significant bleeding, prostration, and jaundice. Sometimes you will find that they are severe anemic, having renal impairment, hypoglycemia, pulmonary edema, shock. Yes, they are in travel list. Yes, probably they may be having severe malaria. Sometimes the patient do not show any of these symptoms or signs, but their parasite count may be more than 200,000. I showed you a case. He had only fever, but his parasite count was more than 200,000. Then we have to consider that patient as severe malaria patient. What will you do? Because you suspect, then you have to diagnose this patient. How? There is microscopy available, thick and thin smear, and the RDT. Almost all the base hospital and above hospitals in Sri Lanka, this microscopy done by the public health laboratory technician and the RDTs are available. So if you suspect, yes, you can refer these patient into these hospitals and get it checked. But you have to make sure single testing won't exclude malaria. You have to do 3 consecutive samples to exclude malaria if it is negative. But if it is positive, no issue, you can directly confirm as malaria patient. So RDT very easy to perform and you can give the results within 15 minutes and based on the band, like COVID testing kits, the bands there, you get the bands. Based on the bands, you can diagnose that patient as is a malaria patient. But RDT is not adequate to confirm the diagnosis and the start treatment. Then you have to do the thick and thin smear to exclude malaria because RDT gives only the species. But for the management, we need the parasite count, the stage, and the species as well. So that's why the microscopy is the gold standard. But the issue is, as I said earlier, you need to do 3 consecutive tests to exclude malaria from these testing. So if you need help, there is the AMC hotline, 071 284 1767. Yes, we have the WhatsApp number also, the same number. So it will help you to diagnose, get advice on how to diagnose, where to diagnose, and to advise on the RDT, where it is available, and the treatment. If you need to know where the treatments are available, you can contact this hotline and get idea and the severe other drugs. And if you want to refer this patient to anywhere, especially the regional malaria officer, yes, you can contact this hotline and get the advice, the information. What should I do? Malaria algorithm, the patient comes with fever and he has a travel history. He has traveled to endemic country. If they are there, yes, you have to do malaria test immediately. If it is negative on the right side, yes, you have to do 3 consecutive days. But if it is positive, you have to refer the patient into a hospital where a visiting physician, it can be private hospital, it can be government hospital, to get the treatment. Patient cannot be treated at home. Definitely, patient should be treated under a visiting physician, even either at hospitals, private hospital or the government hospital. This is there. So if it is Plasmodium vivax, the treatment of choice is chloroquine. Chloroquine we will give 3 days, 4 tablet, 4 tablet, 2 tablet. But to kill the sexual stages and the liver stages, we have to give primaquine after giving the chloroquine. But for the Plasmodium falciparum, the chloroquine is not enough. Drug is not responsive. So we have to give the ACT, artemisinin combination treatment. These drugs are available in each hospital and there's no need to worry. If the visiting physician is there, the drug is there. But if the patient shows features of severe malaria, either symptoms and signs or the laboratory findings, especially the parasite count, yes, you have to treat the patient in ICU. So very early, sometimes we may not be having the RDT report, microscopy report, but we can start the treatment empirically with the concurrence of the anesthetist and the physician. So if you get any of these patients, please send them early as possible to a place where the facilities are there. So these are the management. But management is not the only methods of controlling malaria, prevention of spread. But mainly, prevention of malaria is very important because our people, lots of our people go into this malaria endemic country and they are at risk of getting malaria parasite from there. So we have to give the chemoprophylaxis. That is the most effective method of prevention, even though there are other methods, especially the mosquito bitings, especially the repellents, if nets there, but the chemoprophylaxis is the major form of prevention of malaria. But the issue is, if you are going to India and Nepal, you can get chloroquine. But if you are going to all the other countries, chloroquine is not adequate. You have to get mefloquine. You might be thinking from where we could get this drug, because sometimes the patient comes to you and say, doctor, I am going next month to African region, Kenya. What can I get? So you have to know whether drugs are available, whether they can get it from the private sector. No, the drugs are not available in the private sector. The drugs are available in the regional malaria officer or the anti-malaria campaign headquarters, and the patient should get different drugs if they go to Nepal or India or the other African countries. And the other thing is, if you are going tomorrow, today you cannot get, because you need a certain strength in your blood for a certain period of time. So you have to get 1 week in advance. 1 week in advance, it's a weekly drugs, both mefloquine and chloroquine. And while you are there, you have to get weekly. And after coming to Sri Lanka, you have to get these drugs for 4 weeks. The drugs are given free of charge. We don't charge at all. But the patient, these people have to come either to the regional malaria officer in your district or the anti-malaria headquarters in Narayanpeta. But there are some contraindications, especially for the mefloquine who are going to African region. Then if there are, especially the people having epilepsy or the major psychiatric diseases, then you cannot give mefloquine, and then you may have to give doxycycline. But the issue is doxycycline is a daily drug. So if they are staying there for a long time, around 1 hour, 1 year, then there will be issue. So sometimes you may have to just give good health education on prevention of other methods. So I am giving you the same slide. A patient with fever walks into a clinic, present with fever for 2 days, headache, body ache, vomiting. You might thinking that this patient will be having dengue. But if you had asked the travel history and if he said that he had been to Tanzania, yes, you may be having the suspect or some kind of empirical diagnosis as malaria, dengue, but you have to test for malaria, and if it is negative 3 times, and if it is positive, you have to treat, and you have to notify the anti-malaria headquarters for the hotline, because we have to start our field activities to prevent spread of malaria. The main part, the dengue. Are there differences of malaria and dengue? Yes, there are differences, but most of them are similar. Especially fever, yes, both of them get fever for dengue and malaria. Body aches, yes, both get. Chills and rigors, usually dengue patients rarely get chills and rigor. I don't say no, but sometimes. But malaria patient, it's very, very common. Travel history, usually absent. Sometimes they may be having travel history as well. But for the malaria, yes, we were to very importantly ask the travel history. Thrombocytopenia, that is the issue. If they are especially having Plasmodium falciparum infection, the mostly they get platelet count below 100,000. So patient comes with fever, body aches, and the report with the thrombocytopenia. Please ask the travel history. They may be having malaria, not dengue. Leukopenia, yes, it's common in the dengue, but some mostly malaria, it doesn't happen. The shock, mainly the dengue people get shock late, but on the same day of the fever, these malaria patient can get shock if they are infected with Plasmodium falciparum. Diagnose NS1 PCR full blood count for the dengue, but here malaria, microscopy and RDT. So these are the differences for dengue and malaria. So 5 questions every GP must ask. Ask this in every patient with fever. Which country did you visit? Travel to malaria endemic area is the most important risk factor. Yes. When did you return? Malaria can occur from 7 days to several months. Incubation is 7 to 10 days. After 7 to 10 days, any patient can get features of malaria after they exposed in these countries. The third one, did you take malaria prophylaxis? Sometimes they may say that I took malaria prophylaxis, but malaria prophylaxis is not 100% effective. Sometimes, even though they got the prophylaxis, sometimes they get malaria as well. When did fever begin? Because important for timing of incubation and testing. And have you previously had malaria? Because sometimes if someone in Sri Lanka recently did not visit to malaria endemic country, but if he had previous history of malaria, they can have relapse as well. So common reason malaria is missed. Yes. Travel list not asked. Mainly, yes, most of us missing this travel history part. And mostly we treat the patient as dengue patient. We assume this dengue patient. So that's why I do not assume. The third one is one negative smear, usually accepted as negative. So that is the huge miss, huge negligence. The other one is the malaria not considered. So since we are in Sri Lanka, we think that malaria is free. We do not consider malaria. And sometimes there is a delay in sending blood film to the laboratory, because usually people also tend to just go next day or a few days later after they were asked to go to lab and get tested. It's in Sri Lanka. So that is the thing. So 3 key features you have to keep in your mind. First, fever, always ask for travel history. The second, dengue and malaria can present the same clinical features. Third, malaria cannot be excluded with a single negative test. So, you have to remember, ask, test, repeat, and notify. So, these are the main things that as GPs we had to think. The things that we should not miss, things that you should ask, and things that you have to specially keep in your mind. So, thank you very much.
Thank you, Dr. Chulasiri, for that important, informative presentation about the current malaria status in Sri Lanka. So now the platform is open for questions, and I saw there are already questions on the chat.
I will check it.
Yes, sir.
Where will be the regional malaria officer in RDHS? So usually in each RDHS region, there is a regional malaria officer. In almost all the RDHS regions, there is a regional malaria officer. If you take Anuradhapura, they are in the same premise, RDHS. But sometimes the RMO office is not in the same premise of RDHS. So if you suspect a malaria patient, and if you want to get connected with this regional malaria officer, the best thing is you contact our hotline. I will tell it again. I will keep that right, then it will be very good to you. Yeah. So this is the hotline, not 712-841-767. So please contact this hotline. Then you can get almost all the details where you should contact who should contact the contact numbers as well. The second question, any GP can keep notification forms of the state hospital sector and inform AMOH of the area regarding notifiable communicable disease, including malaria. Yes, no, malaria is a notifiable disease. So all the doctors, GPs, hospital doctors should inform if they suspect malaria through the 544. The issue is, if you notify it through the 544, it takes time. You cannot you don't have enough time for that delay. So that's why even if you suspect, you have to contact the hotline, the anti-malaria campaign headquarters, because you have to test immediately. You have to treat the patient immediately. The third one, yeah. Okay, third one, are investigations available in private sector? There are 5 diseases: malaria, filaria, leishmaniasis, leprosy, STD. Okay, those are those investigations done by specifically trained public health laboratory technicians. Public health laboratory technicians are available only in the government sector, from the base hospital and above. In the private sector, mostly there are medical laboratory technicians. So some medical laboratory technicians have trained under this from these headquarters to diagnose malaria parasites, but they are not experts. That is one thing. So other thing is RDTs are available in most of the private sector, not small hospitals, but in the bigger hospitals, most hospitals, they have the RDT available. So the best thing is, yes, in the private hospitals, they can do the RDT, but they have to contact us to get it confirmed from the microscopy done by the PHLT. That's why usually they have to contact the hotline and the regional malaria officer to get it confirmed. Are all travelers to India need prophylaxis? Is there any specific regions in India which are high? Yes. That is tricky question, because mostly the malaria is spreading in the northern part. That doesn't say, I don't say that malaria is not there in the southern part, especially Chennai and others. But I recommend to take malaria prophylaxis even if you are going to the southern part. But the issue is these days, there are some issues with the stocks of our chemoprophylaxis. Sometimes our regional malaria officers and headquarters will give the initial doses, and we will give you a prescription to get it from the country where you travel, because in most of the countries where the malaria is endemic, in the pharmacies, the drugs are available, especially the chloroquine is available and the mefloquine is available. So it's very cheap in this country, especially in India. So you can get these drugs, buy these drugs after going. But 1 week in advance drug, and the day that you go there, the drugs definitely we will give when you come to the regional manager office or the headquarters. So specific regions, yes, mainly the northern part, but it doesn't say that the other areas are malaria risk. Can a patient get both dengue and malaria infection together? Yes, definitely. We have treated many patients. The patient was treated and the NS1 was positive. The patient was treated as dengue patient, but since patient had travel history, we did malaria testing and it was positive, and we treated them as well. So there is high chance of them getting bad if they are both having dengue and malaria. That's why even if you suspect and if you treat them as dengue patients, if they are having a travel history, you have to do malaria testing as well to exclude malaria. Is it necessary to repeat RDT? RDT is not a confirmatory test. Repeating RDT is not advisable. So it is usually for the first day. If someone is negative, if the RDT, definitely you have to do the microscope. RDT is usually not a specific test. So RDT, even though RDT is negative or positive, the microscopy is mandatory. after travel to endemic country, how long a person should be vigilant? Yes. After traveling to endemic country and after returning to Sri Lanka, because you know that in Plasmodium vivax and Plasmodium ovale, you can have hypnocytes even for 1 year. But sometimes if you get malaria, Plasmodium malaria infection, it will last for 3 years in the liver. So that's why we kept 1 year. If you had gone to malaria endemic country, return to Sri Lanka, and for within 1 year, if someone comes to you with fever, malaria should be suspected. So patient should be vigilant after coming 1 year. So what we recommend is just after coming to Sri Lanka, 1 month after coming to Sri Lanka, 6 months after coming to Sri Lanka, 12 months after coming to Sri Lanka, come to either regional malaria office, headquarters, or the hospital where the PHLT available, and get the routine malaria testing done. Sometimes you may not have features of malaria, but malaria parasite may be in your blood. So routine malaria testing is always encouraged. Do
Dr.
you?
Pugudu, I'm Praneeth.
Yes, Dr. Nitya.
Yeah. I have received some kits from a medical person who was there at the GP's session 2026.
Okay.
He said the specificity for some species it is not valid, but as you said, some species it is valid. So how reliable to use that kit?
Yeah,
Rapid
because
testing.
the rapid
Yeah.
testing.
Yeah.
Dr. Praneeth, what we say is that yes, for some species, especially for the Plasmodium falciparum, the sensitivity and specificity is very high. Yes, because if it is positive, usually from these RDTs, you will get positive result. But on the other way around, if it is negative, that doesn't confirm that patient is negative. That's why we usually don't recommend only the RDT to do to exclude malaria. But if you have in your GP, if you have RDT test, we are very happy. If you suspect malaria, do this testing because the Plasmodium falciparum within hours the patient can get worsen. So yes, it is better. But if you suspect malaria and RDT, even though it is positive, even though it is negative, always refer that patient to microscopist, the PHLT, to get it confirmed. Always send that patient. Positive, yes, definitely you have to send, even though it is negative, and if he has a travel history and come with features of malaria, always refer the patients into the microscopy to get it confirmed. Okay.
Thank you very much.
Okay, Praneeth. After travel to endemic country, how long? Do you recommend prophylaxis for all travelers visit India? Yes, I think I responded then. Conference, yes. That is also tricky. Sometimes people say I am going to the conference and I stay at the hotels. But we have some cases that patient had even in the night patient had gone to the mess or the to eat something from the outside, then got malaria. So we cannot say that 100% they are protected from this being in the AC hotels and others. But we recommend prophylaxis because that is the only method that you can sure that probably it's not 100% that you won't get malaria. Someone has to participate conferences at hotels in main cities, stay throughout the period in hotel premises, but we cannot 100% recommend that these areas are free of malaria mosquito. Once we confirm, how do we get the medication? You can't get the medication because the patient should not be treated at the private, patient should be, they are being treated either government or private or hospital, but it is done under the regional malaria officer. Whenever there is a patient, our RMO or the headquarters doctors, they go to the patient and we provide the drugs. So as individuals, no, you can't get the medication. Kilosan, yes. I don't know why did you ask that question. I miss question to reply. Okay. Once we confirm, how do we get the medication? Yes. So you don't need to worry about the medication. Whenever the main thing is what you have to worry is, please suspect and refer. If you have RDTs, yes, do it. Sometimes it will be positive, sometimes it will be negative, but you have to refer them for the microscopy. Then we will do all the medication. Don't worry, we have adequate drugs. We will treat the patient. Do we have any special arrangement for travelers to and from Jaffna to India since the vector is yes, because especially for the in India we give chloroquine. So we have a very good program in Jaffna area to provide adequate prophylaxis to these people who are going to India. And if they whenever they come to Sri Lanka, we have kept some posters and other information method in the even in the airport, and we have through our public care staff we have given the awareness of these people on where and how to get tested or screened for malaria. Blood donation is deferred for 3 years. Yes, because I didn't say that in 2021 there was a issue, there was a case, blood transfusion induced malaria cases happened in Polonnaruwa. So it happened because of some issues in the diagnosis and the blood donation. So because of that, even before that incident, it was 1 year. But after that incident, we had to make it 3 years. So still it's happening, but we are discussing to make it 1 year. But so far it is 3 years. Yeah.
Dr. Pobudu, I think Dr. Asita has raised hand. He has a question. Dr. Asita, you can ask from Dr. Pobudu.
Yes, Dr. Asita.
Hi, Dr. Pubudu. I know that you are involved in taking policy decisions in several forums. So I want to ask as a GP, I have seen, I'm working at Anuradhapura Kakirao, you know.
Yeah, I know that.
I have seen monks from Myanmar and some endemic countries going through, but they have strongly and objected to take blood because they have not been checked in the airport. So they are going maybe for several weeks, going in Pindapata and in Padayatra. So how do you take decisions with tourism and those the tourists are visiting for maybe months? They are staying in Sri Lanka. Chinese are working in Sri Lanka and they have been found to have malaria infected, and they have also come with fever and they have taken treatment. So what about the other way, the tourists coming to Sri Lanka from endemic countries?
Yeah, that's a very good question. Yes, we had issues with investigating, especially these monks, especially coming from Thailand, Myanmar. So they objected. But to some groups, we could achieve this investigations. They cooperated with us. But sometimes whenever they object, because we cannot, there are some diplomatic issues going there, then what we do is we make sure that vector is not around, because we do the frequent entomological surveillance around these areas where the monks are visiting, and we make sure that these monks are not spreading, even though if they have parasite and if they are asymptomatic. And we have given the awareness to these organizers. If any monks is having fever or get ill, inform us, and then we are going to get testing to these monks. That is for the monks. And the other, especially the people coming with malaria endemic country, yes, because there are some issues with because they are coming to Sri Lanka and they don't like to get tested. But most people, so what we do is we have increased our fever surveillance. So what we have done is, whenever a foreigner from this travel history comes to the general practitioner or hospitals, we have instructed our doctors, the other staff, to get them tested for malaria as well. Yes, even in Badul, these many areas, we got these patient diagnosed when they come into the hospitals with the features of malaria. On the other way around, routine investigation for these people is difficult. We don't know sometimes whether they are coming to Sri Lanka. We have tried to communicate with the immigration, but still it's not feasible. So still we don't know how many people are coming to Sri Lanka and where do they go in the country. But what we do is we have given enough awareness. If they come with fever, then only usually they get spread malaria. If they come with fever, we ask them to test malaria for these people. Okay.
Thank you. Thank you very much.
From previous question, tomorrow Ministry of Health team leaving country to India to attend conference. How can I ask that? Still, yes, it's still the many people, especially who knows, especially many doctors, they know that they have to get malaria prophylaxis. Sometimes they don't get. How can I ask that question? Yes, they have not come to get prophylaxis for the MCHQ. That's why I know. Can I share the hotline to come? Yes, no issue at all. But please tell them that because the hotline, our female doctors are sometimes the hotline is with the female doctors. Okay, so sometimes they get calls even at night asking the other question, not only malaria. Okay, so please ask them to be professional if you share this contact number because sometimes they are very, very, even they won't miss any call. Even if they miss call, within 2 minutes, they will respond to this call. Who called you and why did you call like this thing? They ask. So please ask them to just to use it professionally because there are lots of calls coming to them as well, especially people if the female doctors are handling the phone, they get these calls. But they just keep it, even though with that calls, they don't stop it. Can I share what? Yeah, I think I have responded to the whole question. Any question you can ask now.
Thank you, Dr. Pubudu. I think now
Okay.
we have Dr. Kiloshini with us. So,
Yes.
as the regional malaria officer, Dr. Kiloshini, would you like to share some thoughts regard to these emerging cases of malaria? And actually, I want to thank her because she's the one who initiated today's session. She asked me whether there is any platform to promote awareness about the malaria early diagnosis and treatment among the GPs. So as the Spice Route Young Doctors Movement Sri Lanka team, we are conducting these monthly sessions through GP Café. So we are really happy for conducting today's session, which was very relevant and timely. So Dr. Kileshini, would you like to say something?
Thank you, Dr. Parami. Actually, I sincerely apologize for the technical difficulties I experienced at the beginning. But I think you all have already gained a good understanding of our speaker through and his expertise to today's session. Nevertheless, I would like to take this opportunity to formally introduce and acknowledge Dr. Chula Siri. Our speaker today was Dr. Pubudu Upekshana Chulasiri, consultant community physician at the Anti-Malaria Campaign, Ministry of Health, Sri Lanka. Dr. Chulasiri is one of the national experts involved in Sri Lanka's prevention of re-establishment of malaria program with extensive experience in malaria case management, clinician training, vector control, surveillance, and strengthening the national response to imported malaria cases while safeguarding Sri Lanka's malaria-free status. He holds an MD in community medicine and has contributed to international peer-reviewed publications on malaria, including severe imported malaria, transfusion malaria, malaria deaths after elimination, and emerging malaria threat. Today, he shared his valuable thoughts on malaria in a malaria-free country. The diagnosis we cannot afford to miss. I'm sure his expertise and practical guidance have been highly valuable to all clinicians. And once again, I sincerely thanks Dr. Pubudu Pekshan Chulisiri for his excellent presentation and the answering all questions. and Dr. Parami for giving us the opportunity to make this awareness with this GP's forum. Thank you.
Thank you, Dr. Kilosini. Actually, I have to appreciate Dr. Kilosini, especially she is the one who coordinated and made me to just do the lecture for this GP Cafe. So actually, I'm really happy that the huge number of crowd doctors attended here. So one doctor has asked the lecture. So I will send it to the doctor, our Kilosini, and she will share that lecture with you. So, and if you have any issues, you can either call hotline or my number. I will tell you, 0718-173-150. I will write it here. 0718-173-150. So you can contact me at any time to if you have any issues regarding the malaria. Thank you, Dr. Parami, as well, for giving us this anti-malaria campaign as the opportunity to present my experience with you.
On behalf of the Spice Route Sri Lanka GP Cafe, I extend our heartfelt gratitude to all participants who joined us for this timely and relevant session. Malaria Still Matters, a clinical update for general practitioners. And special thanks to Dr. Pubudu Chulasiri, consultant community physician, for sharing his expertise and guiding us through the critical discussion on malaria in malaria-free country. Finally, we thank all our colleagues and participants for your active engagement with your questions and sharing your thoughts. As the GP platform, Spice Route Sri Lanka GP Cafe remains committed to providing space for timely, relevant, and impactful sessions that enhance the role of GPs in community health. So, thank you once again, and we look forward to a continued participation in future programs. Thank you, everyone. Good night.
Okay, thank you. Good night.
Good night.